Today I'll be talking about whole person dementia assessment, and I apologize, there is some overlap with the last presenter. Dr. Borson did a great job, and so maybe some of the things that overlap, I guess that just highlights the importance of them. This is where I work. I work at St. Louis University. I actually did my residency and my fellowship here and stayed on as faculty. In the last year, they built a new hospital, and we have a geriatric floor, a geriatric unit that we run, and it's been wonderful. There's lots of common areas. We can get patients out of bed easier. So it's an overall real positive change for us as compared to what we used to work in, which was a very antiquated building, hospital building, and we didn't even have chairs to get people out of bed in their rooms. Down below is the college campus. The North Campus is separated from the Health Campus, and then, of course, the Gateway Arch. I have no financial disclosures. So today I'm hoping that we will talk more about the impact that dementia has on both the patient and the caregiver. We'll also talk about normal aging and try to differentiate this from mild cognitive impairment and dementia. And we'll discuss and identify the most common types of dementia, and then I will talk about some of the screening tools that I use for dementia, which Dr. Borson did go over them. So 1 in 3 older adults develop some form of dementia, so that points out how common this really is. Over 6 million Americans are living with Alzheimer's dementia. This number is expected to increase to over 13 million by the year 2050. So between the years of 2000 and 2019, deaths from heart disease decreased by 7%, but deaths from dementia have increased by 145%. And interestingly, dementia is the only cause of death among the top 10 causes of death in America that cannot be prevented, slowed, or cured. There's a huge economic impact, and this largely stems from the unpaid care for loved ones with dementia that Americans provide. So there's over 16 million Americans providing unpaid care, and they provide 18.4 million care hours. And this is valued at over $250 billion. In this year, 2021, dementia will cost our nation $355 billion for healthcare and caregiving cost. And we know that Medicare, Medicaid, and private insurances do partially cover some of these costs, but really the greatest expense burdens covered by the family. There's also a huge emotional impact of dementia. So half of the patients with dementia suffer from depression, and it's the same for caregivers. Half of caregivers caring for loved ones with dementia also suffer from depression. One of the big questions I get in clinic is, are there normal changes in memory with age? And the answer to this is yes. So there's a slower recall of information, such as names. There's also an increased effort needed to learn new tasks. This is why older adults tend to have more trouble learning how to use the computer or an iPhone. There's greater difficulty multitasking, and I'll hear this most often from older women. They'll say something like, when I was younger, I used to be able to cook dinner and balance a checkbook and talk on the phone at the same time. And now I have to, attend to one of these tasks. I have to focus really hard to complete one at a time. There's an easier distractibility, and also there is a slower processing speed as we age. But I think it's important to note that dementia is not normal in the older adult. So how exactly do we define dementia? It's technically defined as memory impairment plus a decline in one or more cognitive domains. So we have 6 cognitive domains. These are learning ability, social function, visual spatial function, language, complex attention, and executive functioning. So you need a decline in one of these areas plus memory impairment. There has to be a significant decline from previous abilities. And this is often I have to get a lot more history to figure out what was happening 10 years ago or 20 years ago, and how has that changed over time. So in order to really diagnose dementia, you have to know what the person was capable of at once. There has to be an impairment in daily functioning, and then the decline is usually progressive and disabling and is caused by damage to the brain. So there's many types of dementia. There's Alzheimer's, vascular, Lewy body, frontotemporal, and Parkinson's disease with dementia. There's also more rare types, but these are our most common 5 types of dementia. Dementia is the umbrella term we use really to describe the range of symptoms associated with cognitive impairment. So about 5 to 8% of people over 65 have dementia, and over 40% of those greater than age 90 have dementia. So it really increases quite drastically with age. The prevalence increases by 5% every 5 years over the age of 65. So some of the risk factors we know, there's definite risk factors, and then there's some suspected. So age is definitely a risk factor. History of Down syndrome. These patients tend to get dementia in their late 40s or early 50s. And it's pretty fast. It's an Alzheimer's type dementia, and it's pretty quickly progressive. Family history also can be indicative of increased risk. And then we talked about during the Wheel of Fortune, the ApoE4 allele is a risk factor. And then there's these possible risk factors: head injury. So any sort of traumatic brain injury can predispose one to developing memory impairment. A lower education level, late onset of major depression, and then the cardiovascular risk factors will increase one's likelihood for the development of vascular dementia, which we'll talk about. So I know Dr. Borson talked a little about this. What are the implications for healthcare providers? I think that the dementia diagnosis really changes our approach with the patient in several different ways. For one, it causes us to question, do caregivers need to be present during the office visits or called to be updated after visits? So how do we best convey information when we know the person we're talking to has cognitive impairment? And maybe this should be done written and verbal, which often in clinic we do provide now with the after visit summary. And then it also has us question, is there a pattern to repeat hospitalizations or ER visits, that may need to be addressed? Is the patient receiving enough oversight at home, and is that why they keep coming back to the ER for seemingly simple things? I was recently on the geriatric consult service in the hospital, and there was a patient that came into the ER because he needed a Band-Aid. He had fallen a week before and had a skin tear, and he didn't have any Band-Aids at home. He just needed to change the bandage that was already placed at another ER visit for the skin tear. So him and his wife both had dementia, and neither one of them could problem solve or had the support to, go to the store and get the Band-Aid. So he just took an ambulance into the ER. And so luckily the ER called and that flagged them to say, hey, I think something's going on here. He was here a week ago because he fell and had this minor skin tear, and he's back now, and all he wants is a bandage. So then I was able to assess him, or our consult team was able to assess him and provide, more comprehensive care. And then if we know that the patient has dementia, we can then turn our sights to the caregiver. Are there signs of caregiver burnout that we can assist with? And then I think having a diagnosis of dementia also causes us to question, the overall big picture. So what is this patient's life expectancy in relation to the dementia as well? And how does seeing this big picture change our management? So for instance, if someone is 80 years old and has advanced dementia, are we going to go ahead and pursue that screening mammogram? Or does the dementia diagnosis change maybe our approach in preventive management? So mild cognitive impairment should be differentiated from dementia. And mild cognitive impairment, when we talk about that, or MCI, we're referring to memory impairment that's significant enough to be noticeable to the family and or the individual, but not significant enough to interfere with daily activities. Whereas in dementia, you're going to have the impairment with daily activities. So mild cognitive impairment occurs in about 10 to 20% of older adults greater than 65. It is an established risk factor for the development of Alzheimer's. About 30% of those with mild cognitive impairment progress to Alzheimer's each year, but that it's important to know that 70% of patients or people with MCI don't progress. And when I give this diagnosis in clinic, I always remind, the patient of this, that we don't really know what causes some people to progress and some people to stay the same. But this, having mild cognitive impairment does not guarantee that you'll go on to develop dementia later. This is just a simple graph that shows the stages of development and progression of dementia. On the far left, we've got the preclinical phase. This is that silent phase where there's changes happening in the brain. Oftentimes it's in the patient's or the person's early 40s, late 40s, early 50s. So there's these changes happening, but there's no clinical symptoms, there's no signs. And some people just, have these changes in their brain that you would see on autopsy at death that never amount to any sort of clinical symptoms of memory impairment. But some people go on to develop mild cognitive impairment. And again, the blue line there shows, the light blue line shows that there's this group of people that develop mild cognitive impairment and they just stay in the mild cognitive impairment range. Whereas there's that percentage each year that progress into the dementia category. So again, in mild cognitive impairment, there's going to be those cognitive changes that are noticeable but not interfering with daily living. And then in dementia, the cognitive impairment severe enough to interfere with everyday activities and also to be noticeable to the family and the patient. So oftentimes in the hospital, when I work on the hospital service, we are tasked with differentiating dementia and delirium. And they have a lot of overlapping features, and they often co-occur, especially in these hospitalized patients. So the distinguishing signs of delirium are really an acute onset. And there's a fluctuating cognition over hours to days, which you don't often see in the stable dementia patient. And there's also an impaired consciousness and attention and altered sleep-wake cycles in patients with delirium. So on the right-hand side, that's the confusion assessment method, or CAM. It's one of our screening tools for delirium that we use to diagnose delirium. And it was developed more in the ICU setting. But you have to have feature 1, which is acute onset of changes or fluctuation in the course of mental status, and also feature 2, which is inattention, and then either feature 3, which is disorganized thinking, or feature 4, which is altered level of consciousness. So if you have 1 and 2, and either 3 or 4, then you have a high chance of having delirium. Dementia versus depression. Dr. Borson talked a little about this as well. The symptoms of dementia and depression also often overlap. You see impaired concentration in both, kind of a lack of motivation, apathy or loss of interest, and then psychomotor retardation. And there's often sleep disturbance in either dementia or depression, where the person sleeps too much or too little. But patients with primary depression are unlike those with dementia in that they demonstrate poor motivation during cognitive testing. The cognitive complaints often exceed the measured deficits, and patients with depression tend to maintain language and motor skills. So I can always kind of pick up on clues when patients are more depressed than they are demented. So for instance, they'll tell me, I just can't think clearly. I just can't think clearly, and I'll administer the test and I'll say, I can't do it. I can't do it. This is too hard. I can't do it. Or they'll tell me that their thought processes are, I can't think, and then they get, 29 out of 30 points on their memory test. And that prompts me to think more, maybe it's a mood disorder, or to ask more questions about the mood itself. And the good news is that treatment of depression often improves cognition in these patients. So next we'll talk about the main types of dementia, and then we'll go through how to screen. So Alzheimer's dementia is the one that we're all most familiar with. What causes it? The pathophysiology is not fully understood yet, but we know it develops as a result of a complex series of events that takes place in the brain over many years. There's definitely genetic, environmental, and lifestyle factors that contribute to the development of Alzheimer's. But in general, it's caused by accumulation of plaques and tangles in the brain. These cause neurotransmitter deficits and a cycle of inflammation and cellular death. The early onset form is rare. We consider it early onset if it occurs before the age of 60, and the early onset form only happens in 1 to 2% of Alzheimer's cases. It's more common in patients that have a diagnosis of Down syndrome. The late onset form we consider develops after the age of 60. So Alzheimer's was named in 1901, or discovered in 1901, by the German psychiatrist Alois Alzheimer. And Alois worked in a mental institution in Frankfurt, Germany. And his first Alzheimer's patient was a woman by the name of August Dieter, who was brought in by her husband. Her husband was a miner, and he would leave for long periods of time and go work in the mines. And what he was finding is that his wife was not able to be left home alone. The neighbors were complaining that she was, out yelling at all hours of the day and night, and that she had these strange behaviors. So he was unable to leave her alone, so he dropped her off at the mental institution. And after she passed away, Dr. Alzheimer examined slides of her brain and found these plaques and tangles. So the plaques are caused by an abnormal protein fragment called amyloid beta, and they occur outside neurons. The neurofibrillary tangles are made of tau protein and occur inside the nerve cells. And so all in all, this abnormal protein accumulation leads to increased inflammation and cellular death. And this cycle just repeats itself, this inflammation and apoptosis, or cellular death, and it causes damage and brain tissue loss, essentially, or atrophy. So these are some famous people that died of Alzheimer's disease. So normally when I'm in an audience that can talk back, we would have guesses on who each person is, but I'll tell you. So on the far left, we have Rita Hayworth. And then of course, everyone recognizes Ronald Reagan. And then the third person is Jimmy Stewart. And then the top right corner, that's Rosa Parks. And then the bottom is Gene Wilder. He's Willy Wonka, the original Willy Wonka. So in Alzheimer's disease, this is a cross-section of the brain. In Alzheimer's disease, you have this brain atrophy or shrinkage, and this occurs from the accumulation of those abnormal proteins and the cycle of cell death. And what I'll have you notice is that in the hippocampus, right here, this is the area of the brain where we form new memories and store memories. In Alzheimer's disease, it's disproportionately affected. So you can see over here, this is the Alzheimer's disease brain. Right here, that there's a big open space where there was healthy brain tissue on this side. There's cellular death and missing brain tissue over here. And so this is why in Alzheimer's dementia, it's hard to remember and to store new memories. And then you can also see just the overall brain shrinkage and a dilation of the ventricles because of the loss of brain tissue. This is what an MRI looks like. So on the left here, we've got the Alzheimer's brain. The black is the cerebral spinal fluid. And as the brain tissue atrophies or shrinks, you have more filling in of the spaces, just the empty spaces with the cerebral spinal fluid. So you've got a lot more CSF in this brain than you do in this brain. This is the healthy brain. And again, here's those hippocampus where we form our memories and store them. And you can see they're missing in the Alzheimer's brain, but we can see them here well in the normal brain. So this is what we call an amyloid PET scan, and it's used mostly in the area of research. It's very expensive and not widely available at all institutions. I know at St. Louis University, we don't actually have an amyloid PET scanner or an ability to test for amyloid, but what this highlights is that there's, the colors here are as the colors start, it's the amyloid deposition. But what it highlights is that there's this preclinical stage where there's starting to be changes in the brain, but there's no symptoms. And this progresses. So here we've got a lot more amyloid deposition you can pick it up on PET scan, and you've got the mild cognitive impairment. And then here, where there's a lot of areas of red, there's a lot more amyloid, and the person has dementia. There's stages of Alzheimer's, mild, moderate, severe. Often we classify it as that, or I use those terms to kind of explain to the family where the patient is at. It's really a gradual, Alzheimer's is a gradual onset type of dementia with a progressive decline, which we'll see is different than some of our other dementias, such as vascular disease. Motor symptoms are pretty rare early in the disease course, but tend to develop much later on. We think about the life expectancy from if there's an early diagnosis that occurs, is about 8 to 10 years. The mild stage lasts from anywhere from 2 to 4 years, and then it's different for each patient how they progress, but in general, the moderate stage is usually 2 to 10 years long, and then the severe stage is the shortest, lasting 1 to 3 years. This is the fast stages of Alzheimer's. It's another classification system. We use this more in the hospice realm. For instance, fast stage 7C is where we say they're appropriate for hospice on the basis of Alzheimer's diagnosis alone. So as you see, it kind of gives families another idea or way to determine what's going to happen next or how fast someone may progress. Although again, it's very individualized per person. Oops. So 7C is when we say they're ready for hospice, they usually are non-ambulatory, nonverbal, unable to speak much, incontinent, unable to independently dress by that point. So moving on to vascular dementia. So vascular dementia is caused by poor blood flow or ischemia. So anything that causes this, so strokes, diabetes, anything that causes small vessel disease or narrowing of the blood vessels in the brain. High blood pressure, high cholesterol, atrial fibrillation. Atrial fibrillation can cause vascular dementia because of the small blood clots that it can occur. Usually we think of this type of dementia as a more sudden onset as opposed to Alzheimer's, which is more gradual. And vascular dementia often has this stepwise progression. And sometimes I can get the history from the family that this has occurred. It makes it much easier when the family can kind of relay, mom was okay, she had that stroke and she, was never the same after her first stroke. And then she cruised along, was fairly stable. And then she had a UTI or pneumonia. And then she sort of stepped down again. And, we're back to kind of being steady. But then she had this fall and she sort of stepped down and she hasn't been the same since the fall. Sometimes I can get a history like that, and that clues me in that it sounds more of a vascular, vascular type picture versus Alzheimer's. Well, it started very slowly and it's just slowly gotten worse over time. That's more of the Alzheimer's trajectory. So with vascular, there's often these abrupt changes in cognitive ability. And in vascular dementia, future damage can be prevented or slowed by aggressive control of chronic medical conditions. So controlling diabetes, controlling blood pressure, anticoagulating for those with AFib, that sort of thing. So vascular dementia used to be called multi-infarct dementia, but it was renamed vascular dementia. You'll still hear some people call it multi-infarct, because we think vascular dementia can occur without an actual infarct, happening, without evidence of the actual stroke, because all it takes is this narrowing of blood vessels in the brain to give this picture of vascular dementia. On the right, there's a scoring system. It's called the Hachinsky ischemic score. This helps differentiate Alzheimer's disease versus vascular dementia, especially in the research setting when you're trying to enroll patients in just, studies of vascular risk factors, say, or treatment of vascular dementia. You would need some sort of scoring system to kind of differentiate the two, and this is just one example. So with imaging in vascular dementia, you tend to see these white matter changes, what we call white matter changes, or ischemic small vessel disease. So you can see on the top all those little areas of white around the ventricles here in the white matter. This is examples of small vessel disease. And then on the bottom here, you can see someone that actually had an occlusion in one of their main blood vessels, and that led to an actual stroke. So this brain tissue here will ultimately atrophy and die and just become dead tissue. So in vascular dementia, the symptoms tend to correlate with where in the brain the stroke or blood vessel narrowing occurs. We call this a Swiss cheese brain. And sometimes the history I get for something like this is that, they think my mom thinks clear in certain areas, but other areas she just isn't right. So that's where I think, well, maybe, that's where the narrowing in the brain has occurred, whatever part, is affected. It tends to be just right where the narrowing occurs or where there's been a small infarct. So next we're going to talk about Lewy body dementia. This is my personal favorite because I think it's really underdiagnosed, and I think we have a lot more work to do in the area of Lewy body dementia. So Lewy body dementia is caused by abnormal protein deposits, or Lewy bodies, that occur in the cytoplasm of neurons in the brain. It's on the same spectrum as Parkinson's disease, and often can be hard to tell apart, especially in later stages. It's more common in men. The symptoms are are pretty prominent. They're different than vascular dementia and Alzheimer's, but visual hallucinations are very prominent and very common. And often these occur way ahead of the memory deficits, or with a mild memory deficit, they're having prominent visual hallucinations. That's sort of your cue that it may be Lewy body. In more, as things progress, there's often a fluctuating attention. There can be motor dysfunction, similar to the motor dysfunction you see in Parkinson's. I will say you don't see as many of the hand tremors, the tremors at rest. What you'll see more so is the bradykinesia, the freezing episodes. You'll see more of the posture, abnormal stooped posture and falls that you see in Parkinson's patients. It's also very common to have abnormal movements during sleep. So it's part of Lewy body is a REM sleep disorder. Part of the diagnosis can include that. And usually what you'll hear on that is that the person acts out their dreams. So you'll have the spouse say, yeah, my husband moves around a lot. A lot of times he'll be flailing his arms and he'll hit me. I can't even sleep in the same bed. Or you'll hear a history of that maybe 5 years ago type thing. Like I said, it's widely underdiagnosed. So this, again, the symptoms are dependent on where in the brain the Lewy bodies are actually depositing. Typically, the Lewy body formation or deposition starts in the peripheral nervous system. They say the first symptom is actually constipation, but that's so nonspecific. It usually then moves into the CNS, into the brainstem, and upwards towards the motor cortex. So if deposits, these Lewy body deposits, form in areas that release acetylcholinesterase, you may have more of an Alzheimer's type symptomatology, because that's the main neurotransmitter affected in Alzheimer's disease. But if the deposits form in areas that release dopamine, you'll have more of a Parkinsonian type feature. So that's, again, dopamine, usually you see alterations with in Parkinson's disease. The deposition of the Lewy bodies in the occipital cortex is what leads to the hallucinations. And that's why they're so prominent early on. So you can see on the left here that in Lewy body dementia, the motor dysfunction often looks like Parkinson's. They often have profound autonomic dysfunction. That's where you have the falls, you'll have orthostatic hypotension, you'll see bradycardia. The acting out dreams, or the REM sleep behavior disorder, and or other sleep disturbances. The cognitive dysfunction can look like Alzheimer's, and there's fluctuating levels of attention that may mimic delirium. Often these patients get diagnosed, often inappropriately, with recurrent UTIs, and they'll say, well, that's why they were delirious, but it's really a Lewy body picture. Whereas if you just give it a day, you don't need to treat. There's no, the urine culture is negative. We don't need to treat with antibiotics. This is Lewy body, and this is part of the pathology of the disease. And then visual hallucinations. And the other one that I didn't mention is that in Lewy body patients, they have a very high sensitivity to antipsychotics or neuroleptics. So I learned this the hard way one time. I misdiagnosed a patient. I thought he had vascular dementia and he was having some hallucinations. I put him on an antipsychotic and he got much, much worse. And that was my first clue, is, oh, maybe this is Lewy body. He was seeing little elves. His wife called to say he was seeing elves in the room, the living room. He would sit in his chair and he would see them. And they were starting to become distressing. And he would even say, well, you can't sit on the couch because someone's sitting, the elves are sitting there. And so we tried a low dose antipsychotic and it really didn't help. So I increased the dose. And then the next call I got was that he was hitting the elves with a golf club, and he had made a bunch of holes in the wall. And so we got him admitted to the geriatric psych unit, and that's where he was appropriately diagnosed with Lewy body. And it made me question. Now I'm much more conscious of the Lewy body pathology and that maybe I should be looking out for it more. So these are some famous people that died of Lewy body dementia. Robin Williams. This is a Chicago Blackhawk coach. I think his name was Stan Mikata. This is Casey Kasem. This is Estelle Getty from the Golden Girls. This is Jerry Sloan from the Bulls. And this guy, I don't remember his name, but he was the creator of the lawn flamingos. He patented them. So in terms of imaging, Lewy body is not really, you can't really pick it up on MRI. The control brain here is on the left, so this is a normal healthy brain. And in the middle here, you've got the Lewy body brain, which looks very similar to the control brain. You may have a little bit more atrophy in this brain, but And again, the hippocampus here, you can see it's preserved in the Lewy body brain for the most part, maybe just a little bit of black space. And then in comparison to the Alzheimer's brain, which you have a much more atrophy here with much more black cerebral spinal fluid space. And then the hippocampus there are definitely missing. So it's difficult to pick up on imaging. We do have a PET scan that can help clue you in, but again, this is not widely used in the clinical setting. And we don't have a PET scan for, for Alzheimer's, we have a PET scan that detects actual amyloid deposition. We don't have a PET scan yet that detects actual Lewy body deposition. So what we look for is glucose uptake. So this is an FDG, so a glucose uptake scan. And what we see in the Lewy body brain is that there's low uptake in areas where these Lewy bodies deposit and cellular death occurs. So in Lewy body, we tend to see these more in the occipital regions and sometimes in the parietal regions. But in the occipital regions, this is what part of our brain is responsible for our vision. And so that's why when there's damage that occurs to the occipital region, we have the hallucinations that can occur in these patients. So next we'll talk about Parkinson's disease with dementia. It's very similar oftentimes to Lewy body. You know that Parkinson's is a chronic progressive neurological condition. The symptoms include tremors and muscle stiffness and masked faces and then the slow shuffling gait. About 80% of patients with Parkinson's disease will eventually develop dementia if they live long enough. In Parkinson's disease, the memory loss is often accompanied by high rates of depression, anxiety, and then they also have hallucinations that are more prominent than the Alzheimer's patients. Parkinson's disease patients often have marked impairment in their visual spatial functioning. So even before the memory per se starts to decline, they'll have problems parking. That's what I'll hear is that dad keeps running over a curb. So there's an earlier concern with driving in these patients because their visual spatial function tends to be more impaired than their other cognitive domains. So Parkinson's disease with dementia is very similar to Lewy body, and the two can be hard to tell apart at later stages, but timing is what differentiates. So in Lewy body, the memory impairment precedes or accompanies the motor symptoms. And in Parkinson's disease with dementia, the motor symptoms usually see the tremors, the shuffling gait, all of that. It precedes the memory impairment by at least a year, but usually we're talking 10 years, honestly. So our last dementia we're going to talk about is frontotemporal dementia. And I would say I have the least amount of experience with this dementia. My clinical activities focus on patients over 65, and this is one of the dementias that occurs in patients younger than 65. So by the time I see them, the diagnosis is often made, which is good. So frontotemporal dementias are also known as Pick's disease. And it results from the progressive degeneration of the frontal and temporal lobes. So that it's out of proportion to the rest of the brain degenerating at these frontal and temporal lobes. And so the frontal lobe is where we think of personality. And so it tends to be what they present with are personality changes and a decline in social skills and really this inability to understand and read another's emotions. It can affect language and motor skills, but this is usually later on in the disease course. The behavior and personality changes manifest long before the memory loss. So a typical history you'll hear in someone with frontotemporal dementia is that, well, I thought my husband was just going through a midlife crisis. Everything changed. Around the age of 55, he just became a different person. He started gambling, or he went out and he bought this Corvette and he was driving really fast. And he just didn't seem to care anymore about the family. And so oftentimes they'll be diagnosed with either a personality change, like the, personality crisis is what we call it, but they'll be diagnosed with a psychiatric disorder, like some sort of personality disorder, when really later it becomes apparent that this was probably early changes of frontotemporal dementia. Frontotemporal dementia is the most common type of dementia in people under the age of 60. So here's what the brain looks like. You can see up here, there's kind of some faint red circles, but this is kind of the temporal area of the brain, and you can see that there's a lot of degeneration. I mean, this back part of the brain looks normal and healthy, and then you can see a lot more empty space here with the black, the cerebral spinal fluid. Same for this, and then up here, you can see this is the frontal lobe. So you can see that is definitely shrinking in proportion to the rest of the brain. So now on to making the diagnosis. Now that we're all experts in the most common types of dementia, how do we differentiate them in the clinical setting? So one of our goals is to rule out reversible causes. And then after we rule out the reversible causes of memory impairment, we're going to try to distinguish between the various types of dementia. This often takes more than one clinic visit, I will say. And then throughout, we're going to try to build, our ultimate goal is building a comprehensive treatment plan. So looking at the biopsychosocial care really tailored to the individual. So at the first visit, we'll get a complete medical history. We'll do our physical and neurological examinations. I'll show you in the next slides what tests I prefer to use. Since I'm from St. Louis University, I use the St. Louis University mental status exam or the rapid cognitive screen, which I'll show you too. And then I usually, if the patient hasn't had any head imaging in the last year or two, I will always start with a CT or MRI, depending on what they can tolerate. And what I'm really looking for in my CT or MRI is any changes that would be consistent with vascular dementia. The patient always wants to know if they have a brain tumor, but I will say in the clinic setting, I've never discovered a brain tumor. I've seen that on the inpatient side, inpatient hospital medicine, but not someone just coming for memory concerns. I've never diagnosed that, but that's the patient and the family's concern. In laboratory tests, we look for reversible causes. So we always do a B12, a TSH. We used to do an RPR for syphilis. Will say I've gotten kind of out of the habit. It was negative 1 million times and I don't check it as much anymore, but you can easily add that in. And there has been one occasion where I should have checked it and I didn't, and the patient was diagnosed much later with syphilis. The neuropsych assessment is optional. So this is more in-depth cognitive testing. So I'll show you my screening test, but if there's questions about the performance on the screening test, really in patients that outperform screening tests. So teachers, lawyers, doctors, anyone with a high educational level can outscreen their test. You know, they can get a very high score on their memory test. And then you have the family saying, well, they're just not thinking clearly, there's something wrong with their memory, then I'll send them for one of these more in-depth neuropsych assessments, which at my institution, I think is about a 4-hour test, and it's conducted by a neuropsychologist, and there's no way to fool the 4-hour tests. They definitely can pick up very subtle changes. And the longer assessment looks in depth at each cognitive domain and can send a good report saying which cognitive domains are impaired. So at the present time, I think it's important to note there's no single diagnostic test for detecting mild cognitive impairment, Alzheimer's disease, or other types of dementia. So families often ask this question, well, what test can you do that shows whether my mom has Alzheimer's or not? And there's no simple answer for that. It's really a big picture. And so we do all of these things to put the big picture together. And I do tell them up front, I may not be able to give you an exact diagnosis the first visit, because sometimes we have to kind of track how it changes over time. And that's what gives me a clue. If it slowly changes, slowly progressive over time, that looks more like an Alzheimer's picture for me. Versus, if the next visit they come in and they tell me that they're having a lot more hallucinations and I knew they did fairly well on their memory test, that looks more like a Lewy body picture. So there's a mnemonic that we use to rule out the reversible causes. And I like mnemonics because it just makes sure I don't miss anything. So I still find that sometimes I turn to them just to make sure that I'm covering all my bases. So for this mnemonic, it's dementias. So D, drugs, E, emotional. We're thinking more like depression or any sort of mood disorder. M, metabolic. E, eyes and ears. So is it that they're not hearing? We put hearing aids in them and they suddenly can hear us in our screening test and they do much better. N is normal pressure hydrocephalus. T, tumor, which again, I haven't really diagnosed much in the clinical setting. I, infection. A, AFib or alcoholism, and then S is sleep apnea. So we think about 10% of patients that present to us with mild cognitive impairment have some sort of reversible cause. So it is important to look for it. It's very satisfying when it's something easy, like you get a history and you find they have sleep apnea and they go for a sleep test and then they think much clearer once they're started on their CPAP. So it makes it worth really going through the list and being thorough. So this is the slums exam. I know Dr. Borson mentioned it. This is what I use at every new patient visit, and then I use it as needed thereafter, just to track changes in memory. What I like about the slums myself is that it's adjusted for education level. And I have two different clinics. I have one that's in the inner city, and I have one that's in the county. And I think it's important to adjust for the education level because they're different in the different clinics. And I think it also may change, people's intrinsic abilities. I would say this takes me probably about 7 minutes to administer. We also have a short form of it. This is the rapid cognitive screen. So this is taking 10 points from the slums that I just saw you. And so it's much more concise. It probably takes 4 minutes, 3 to 4 minutes to administer. And then this is looking at, we had in 2015 one of our statisticians did some research looking at the rapid cognitive screen versus the mini cog. And you can tell that, so the mini cog is the blue line here, and the rapid cognitive screen is the green line. And so what you're looking for here is the area under the curve. And so it looks like that the rapid cognitive screen was better at picking up dementia and mild cognitive impairment. But this is debatable. I think you just find a screening test that you're most comfortable with, and that is easiest for your staff or yourself to administer, and sticking with it, because really the goal is using something, as Dr. Borson pointed out. We miss a lot of opportunities to screen for mild cognitive impairment and dementia. So just picking something that you're comfortable with and doing it is important. So she talked a little about the early diagnosis of dementia. I think I just have one slide on it. And I think it's important because it can identify any potentially reversible or treatable causes. And these can potentially be corrected before permanent damage to the brain is done. I also think early diagnosis is important because it can facilitate planning for patients and families. And when I say planning, I mean this includes naming a POA, or getting finances in order, or discussion of medical preferences. You can have these discussions more with the patient than with the family, and really get an idea of what the patient themselves, their goals are, before they're unable to articulate those goals. And so it really, having an early diagnosis of memory impairment really helps tailor our healthcare to, the patient, in providing patient-centered care. And then we can address critical safety issues such as driving and living alone before a crisis occurs. I've seen a lot of crises, and I always think if we could have gotten this diagnosis established ahead of time, maybe these crises would have been prevented. One time I work at the retirement community, and one time I had a daughter call. So I go to this retirement community every Tuesday, and every Tuesday I would come, and there would be this big RV or Winnebago in the lot of the retirement community. And for 2 years, I never knew whose that was. I assumed it was the facility that owned it, but it turns out it was a patient. And one day I showed up and the Winnebago was gone. And I don't think I really realized it, but that same day a daughter called, and it was a daughter I had never met before. And she said, "I don't know what to do, but I heard that you're a doctor, and I heard that, you're here today and that you specialize in older adults. I just picked my dad up from Louisiana. He drove that Winnebago that was out in the parking lot, and they found him lost in Louisiana. And the police called me yesterday and said that he was there and he'd been missing for 3 days." And this patient had decided he was going to go on a road trip. He was actually in his lifetime an over-the-road truck driver. So he felt very comfortable driving, but he had undiagnosed dementia. And it wasn't safe for him to be driving, especially this Winnebago. He in his head, he was going to drive to Texas where his son or her brother lived, but he didn't make it. He got lost, and he drove through the night without stopping to get any food or water. So he really had been driving for at least 24 hours without stopping to sleep or getting anything to drink or eat. And he got even more confused and was found on the side of the road confused. And the police took him to the hospital, where they called the daughter and she picked him up. So she brought him to me literally, right from the trip from Louisiana. And his memory test score was so low. I was horrified that he was still driving. And she had said, well, this was the 3rd time he'd gotten lost, but the other 2 times weren't as bad, So that always reminds me of the importance of early diagnosis, because at that visit, we took away his keys. And he still continued to go get in his car because he had a bunch of spare sets of keys, but then we disabled his battery and we were at least able to make things safe so that he wouldn't get lost again. The other crisis that I've heard about several times is financial. So relatives getting scammed by these financial scammers and the family not necessarily realizing that they were unable to make good decisions, and that they would, that will never happen. My mom would never give away thousands of dollars to someone calling her on the phone. Well, it did happen. And once that's done, it's done, and the money often doesn't come back, and the scammer continues to scam. So it's important, I think, to make the family aware, the patient aware that there's a problem before these kind of issues occur. You can also explain to the family why the patient's acting and thinking different, and allow families really to place blame on the disease process and not the patient themselves. It's not your loved one that's purposefully trying to forget or the purposefully trying to be difficult. It's the fact that these changes are occurring in your loved one's brain, and it's the disease process. And so I spend time trying to shift the focus to that, thought is it's not your loved one, but just what's occurring to them. So I don't know if any of you are familiar with the safe return bracelets. These are through the Alzheimer's Association, but it's something I suggest to families where there's a risk of elopement, in their loved ones. Although most families will tell you, oh, my loved one would never leave the house. That would never happen at our house. But I suggest, once I make a diagnosis of dementia, that they get one of these bracelets. And the number on the back of it, you call if the person's found wandering outside or has eloped. Whoever finds them can call this number, and it doesn't give any specifics about the person's name or identity, but it has one of these ID numbers on it. And the Alzheimer's Association will get into contact with the family and say your loved one's been located and this is where. Then one of the other things that we don't talk enough about, but is equally as important, are guns and dementia. How many times have you asked your demented patients or families with patients that have dementia, are there guns in the home? Because this is, again, another crisis that is very preventable, that once someone's diagnosed with memory impairment and they may not be thinking clearly, it's time to get the guns out of the house. Dr. Morley, who's speaking later today, always told me the story of a patient he had who shot her husband because she got confused overnight. She had dementia. She didn't recognize him. She thought he was an intruder, and she shot him. And so that was very preventable. It's something that I try to keep in mind to ask the question of, at least. And then finally, caregiver support is really part of the whole person dementia assessment. So I wanted to include a couple slides about this at the end here. So knowing that someone has dementia can allow us as healthcare providers to assess for caregiver burden and burnout. And then talking about what resources may be available. So community resources for us, we have a non-for-profit agency that goes into patients' homes in St. Louis and educates families. It's called Memory Care Home Solutions. So, being able to share these community resources with families. The Alzheimer's Association has wonderful support groups. Is it time for maybe private duty nursing if there's no other family members that can provide the caregiver some time away? Are there finances available that just to get the caregiver out a couple hours a week for starters? And then respite care. Are there any nearby nursing facilities that can provide respite care for a week so that the caregiver can go on vacation or, get away? And how can I help the family set these up if they're needed right now? And then I think it's always important to explore feelings with the caregiver about when placement outside of the home may be needed. So I'll ask, how are you feeling? Are you feeling that you're able to cope with the high care needs your loved one has right now? What are your plans for the future? If there becomes a day where you may not be able to manage all these high care needs, what are you thinking? Should we start looking into assisted livings, or at least do you have an idea where you would want your loved one to go if that time comes? What finances are involved? Do you have an idea of the cost? What do the wait lists look like at the places in your area? Should we get your loved one's name on a wait list? And even if you're not ready when the time comes and their name comes up to number one, you can always move their name down on the wait list. But let's plan ahead before the crisis occurs and before you have to put them somewhere that you may not want. And then advanced directives. So the earlier we can make a diagnosis, the more patient participation we can have in advanced care planning. So I think probably you're all familiar with advanced directives, living wills, and powers of attorney. But often in the hospitals where I see patients that have no power of attorney, and it's clear they're very demented, and now they're probably not able to legally sign one. So, in my clinic setting, I try to make sure that we've actually had a conversation that all this paperwork is in place, so that there's no crises, and that it's all just streamlined for if it ever is needed.